America is home to 33 million small businesses, the beating heart of communities across the country.
And proof that the American dream is still alive.
This is a show about those dreamers and doers and the communities they serve.
Their real life stories.
Their struggles and successes.
Their grit, determination, and passion.
And the people who fight
to keep their American dream alive.
I'm Alfredo Ortiz.
I'm Elaine Parker.
And it's time for another episode of Main Street Matters,
America's small business megaphone. What if small businesses could finally offer better healthcare than big corporations at a lower cost? Today's conversation could completely change how entrepreneurs think about employee healthcare. Joining me today is Dr. Chad Savage, founder of Choice Direct Care and a leading voice in the direct primary care movement, which is reshaping how patients and employers access healthcare. Dr. Savage, welcome to the show.
Good to see you again, Elaine.
Well, I see it is Ash Wednesday with your cross on your head. So that is wonderful. And of course, normally with podcasts, you don't know when people film things. But today, this episode, everybody will know exactly what day we filmed this episode. So that's wonderful.
On my ponderous forehead there.
Exactly. Well, let's get right into it. I mean, you've been on the show before. We've talked about the healthcare problems, and I think it's always good to sort of take a step back and kind of recap some of that. Why do you think the traditional healthcare system, as we know it, employer-provided healthcare, and the relationship between doctors and patients, that the whole system of how it's set up right now, why do you think it is so broken and because broken, costly?
Well, it's become incredibly bureaucratized and industrialized. Long gone are the days of Marcus Welby, of that interpersonal relationship between a doctor and a patient when healthcare was affordable. And people would assume that this bureaucracy covering healthcare through insurance companies, the government, and involving employers makes medical care more cost effective, but it doesn't. It actually adds tons of layers of middlemen into the system and separates, even though they may not physically be in the room with the doctor and the patient, they're injecting themselves into that relationship and altering the decision making. So I'm actually what's called a direct primary care doctor. We're a movement of physicians. It's really grown by leaps and bounds over the last 10 years. When I started in 2015, there were a couple dozen of us in the nation, and now there are thousands. And basically, we're trying to reject that extensive bureaucratized system and get back to the doctor and the patient working together, so that we have no interest except for the patient's interest, because we work for them directly. And by doing so, we've massively reduced our cost of operation. We can share that with our patients. And we are also incentivized to help them shop for quality, affordable medical care.
So primary care level, which is what we all think of first when when we're sick or we've got a boo-boo or whatever it is, and we think, I need to go to the doctor, we're going to our primary care physician. So you're like the main brain of our healthcare system and where we come for the initial answers or the treatment that solves the problem. How does that work in terms of if I'm an individual, it's a monthly membership? Is that how it works? Kind of walk us through how that looks.
Correct. So when I was first looking at this, I knew the system was broken. I wanted to get out of it and do something different. And I was looking around and I tried to figure, do you bill like an hourly rate, like an attorney? Do you just charge per, a fee for service, which means every time you come in, the person pays? And I realized there were substantial downsides of each of those models. How could you build a comfortable relationship with a patient if you're billing by the minute, and anytime you just introduce kind of hey, how's your family? Like, hey, doc, no, we're not talking about that. You're charging too much.
Stop the watch.
Exactly. So there was a movement that I was an early adopter of, but not a founder of. Dr. Lee Gross out of Florida, Dr. Josh Umber out of Kansas were some of the originators of this model. And it's basically, they realized that if you create a membership model where you basically pay a set monthly fee that's a fraction of the cost of most cell phone bills. Just as an example, my own practice, our prices are $49 to $99 a month for unlimited medical care through our office. And it's same or next day. This sounds like a sales pitch. This is unfortunately, we talk about it a lot, so it starts sounding that way after a while. Right. but people see us as much as they want, same or next business day. We schedule in 30-minute and 1 hour increments, so you're never rushed. If we don't get through everything in that 1 hour, you can come back the next day and we can keep the conversation going. And we combine it with cash pay meds, labs, and imaging services to massively drive down that cost and restore that doctor-patient relationship, which is one of the reasons so many of us went into medicine. Now, that's so advantageous for the patient because they get what's called first dollar coverage. In the traditional insurance plan, you may have a $2,000 deductible, which would actually be considered good by modern standards, which is shocking, which means you're paying everything up to whatever that deductible is out of pocket, and you're usually getting an absolutely horrendous rate while doing so. Well, our patients don't need to worry about that because that actually delays access to medical care. If people say, geez, I got a cold and, my throat's sore and, I could go in and get swabbed, but, I'll have to pay for the swab. I'll have to take a couple hours off of work to go in there. So there's opportunity cost, the loss of that value of that time you could have been at work or with your family or doing something else. And then I'm probably going to get a $200 charge for just simply seeing the doctor after sitting in the office for an hour. Our patients are able to get, we basically don't have a waiting room. We technically, the physical space is there, but no one waits in it anymore. Our scheduled time is when we see them because we appropriately schedule. We're not overbooked as in the insurance practices. So they walk in the door, they basically walk to the room. In our case, we include the in-office diagnostics. So if we do a strep swab, that's just part of the membership. Those things are actually cheap. This is why we're able to wrap them in. It's crazy to me that we would spend a bunch of time tracking and billing a 10-cent urinalysis when we can just simply wrap it into that cost. So now that patient is seen promptly, goes back to work or whatever they want to do promptly. We get them a couple of $1 medication, let's say if they actually did have strep. And why that's so advantageous is not just the convenience factor, but we're able to find and detect and treat diseases earlier in their course. And because we're afforded the time to really be with our patients, we're able to practice to a higher level of our licensure than the doctor who has 5 minutes and just out of sheer exhaustion just says, just go see a specialist. I don't know, I can't want to deal with this, just go see a specialist. So right. It literally changes it at every single level, re-incentivizing the system.
So the incentives, right. So as patients in the traditional system, the way it's set up, we don't care what the cost of healthcare is. Patients, they don't care. We don't ask for the cost of the machinery that you bought or anything like that. There's two things that patients care about. They care about what their monthly premium is, and they care about what their deductible is, and probably their copays. So maybe three things they care about. But there's no care about the actual cost of healthcare in terms of driving it down. And so I feel like that's the relationship that has to be changed so that as a patient, a consumer of healthcare, I have a stake in the game to help drive down the costs and increase healthcare, the quality of healthcare, meaning change the dynamic of the relationship. And so you mentioned with DPC care, at least in your office, I'm sort of asking broadly, do DPC doctors also handle labs and prescriptions and maybe sort of basic diagnostics or x-rays, initial sort of frontline diagnostics within the offices?
Yeah. So a lot of, just to clarify if I can, your point, you can correct me if I'm interpreting it wrong. I would say that's true. A lot of patients don't care if they have a low deductible, very expensive plan and they're not seeing those costs. We have a growing number of patients who are acutely aware of the costs. Either they have high deductible plans. Again, if you have a $10,000 family deductible, you are paying cash.
Yes.
And if you're in the traditional system, you're getting a CBC, for example, which is a complete blood count. It's a blood test. Our local hospital system charges over $100 for those, and we're able to access those and run those on a patient for $3.50. So that is a staggering savings.
What is that, a CBC test? Is that just a blood test?
Yep, complete blood count is a CBC. And usually doctors will order multiple panels, so it won't just be a CBC. It could be a CBC and a CMP, a comprehensive metabolic panel, and a TSH, a thyroid marker, a cholesterol panel, et cetera, et cetera. Just as an example along those lines, my standard physical exam panel is over $500 at our local university hospital, but if it's $35 when we do it through a direct approach. And basically what we do is we act as a financial pass-through for that patient. We draw the blood in the office, we send it to a national lab. So it's not some crazy guy with Einstein hair in the back room tilting beakers. These are good,
Right.
credible, lab results. In fact, they're the same exact ones that some of the big hospital systems in our area use. We just don't mark it up. And in healthcare, the markup's not tens or hundreds of percent. It's multiple thousands of percent markups on these. They're revenue centers for these centers. Our model, we only make money on the membership. We don't make money on those markups. So we actually act as a pass-through so that by saving money on your meds, because we do the same thing with generic medications, we sell those at cost. We do that with the labs, and we work with partners, an imaging center locally to get things such as an MRI for as low as $350 versus the $4,000 they charge hospitals. So that essentially, once you look at all the savings we get on these other things, they've thrown their doctor in for free because usually it exceeds the amount that our membership costs.
So a blood test, a CBC, a basic CBC panel, $100 at a regular lab, $3 through a DPC doctor,
Right.
average. You mentioned an MRI, $4,000 at the hospital. You said a couple $100 through
Yeah.
a DPC doctor or
How
a partner.
you pay for it matters, unfortunately. I'm in the state of Michigan, and you can go to the exact same MRI, exact same imaging center, and if you pay for cash, they can do it for $350. If you do the exact same radiologist, everything's the same. If you do it through a traditional health insurance, it's around $4,000. If you do it for auto insurance, because they have nothing in my state of Michigan to control that cost, it can be over $10,000. All for the exact same test, exact same center, exact same physicians and technicians performing the test, just modified by how you pay for it. So when we get more people controlling their own assets to pay for these, it's going to absolutely drive down costs, and you're going to eliminate a lot of the fraud that we're currently learning about through Minnesota and other areas where we're seeing massive Medicaid fraud and things of this sort. When people have some skin in the game, they don't want their money stolen. They watch those transactions like hawks, and that also would be massively improved.
So help people understand primary care. You're kind of the mothership of healthcare for the patient. But what happens when we've got either an emergency or a diagnosis that requires a specialist? Is that where you've got a separate insurance plan or high deductible? Talk about some of the options on how somebody pairs DPC plans through someone like you and then having the catastrophic kind of coverage, if you will.
Absolutely. So that's a great pairing of two things, because in primary care, we can probably handle about 75 to 80% of medical issues. And I would argue in the direct primary care model, because we have the time, it may even be higher. And I could extend into how AI is working itself into medical care. And honestly, that could even further extend the capabilities of the primary care doctor. But as it is today, we can do about 75 to 80% of medical issues, but that still leaves 20% that are beyond our scope of practice. So I can't, do an appendectomy. I'm not going to take somebody into the break room, pull out my butter knife, and try to go to town on them. We send those appropriately to the hospital. Well, how do you cover that? That's outside of our membership model. That's why you still do need coverage for catastrophic events, because having an appendectomy, needing open heart surgery, developing a cancer is a catastrophe. So you need catastrophic insurance for those. But thankfully, those do not occur every year. In fact, it's been estimated that in any given year, only 5% of patients would exceed a $5,000 deductible with catastrophic expenses. That's basically 1 in 20 years. You're going to need that insurance. So don't pay for insurance that's so expensive. It's as though you're having a catastrophe every single year. Getting less expensive coverage for that rare event is appropriate. Because it is needed periodically. We're frail human beings, as my ashes demonstrate, ashes to ashes, dust to dust. This is a reminder that we're mortal, because we are. And so we do need to cover those kind of events, and that's why insurance or coverage of some sort, whether they be indemnity plans, health sharing ministries like Samaritan Ministries, short-term limited duration plans, basically they need to broaden this up, stop requiring only the incredibly expensive ACA policies which for a family of 5 are currently estimated at $35,000 for a bronze plan in Dallas, Texas. For an ACA bronze plan, $12,000 deductible. That's $47,000 before anything's even covered. These plans really should go the way of the dinosaur. We should open it back up to patient, market-controlled policies that people actually want to buy without coercion.
So if I'm a small business owner and I've got 10 or 15 employees and I'm done with these high insurance premiums, even though I'm sharing it a little bit with my employees, I'm carrying the bulk of it. It's just too expensive, but I want to provide insurance for my employees. And I decide to go with a DPC plan and pay for it as part of their benefits. How do you work with employers to handle that? And obviously they would be pairing it with some sort of catastrophic plan, as you've described. How does that work? Do you do group plans for employers?
Yeah, we do. Not every direct primary care doctor's office does that, and there are actually conglomerates of direct primary care practices that are working together to work with larger businesses, because obviously an individual practice, like my own, we just talked to a employer that has over 1,000 employees and their families, and my little 3-provider practice couldn't absorb all of that overnight. So we would have to rely on some of the other direct primary care practices to pick up the ones that we couldn't take. So those type of things are developing. We have a number of business contracts already right now, and there are intermediaries that we want to make sure they don't become the new insurance company, but there are some intermediaries that help facilitate that transaction. But my practice specifically, we essentially take our lowest member rate, and if it's more than a 10-person business, we'll offer that as their base level for all their employees. So this is usually makes it more palatable to have a high deductible plan. If an employer goes from a low deductible plan to a high deductible plan, they're going to have a lot of unhappy employees because they're shouldering a lot more of that burden. Saying, well, you have a doctor available 24/7, 365 who will see you for free at any point, makes that a little more palatable when combined with a lower premium. And the hope is by decreasing the premium, that it can more than cover the DPC membership with money left over in their pocket, for both the employer who now is spending less on healthcare, and for that employee who may be able to put that into something like an HSA. So the high deductible health plans usually can be combined with an HSA, a health savings account, which has been recently clarified in the One Big Beautiful Bill, that HSAs can be used to pay the membership of direct primary care. So now you have something like our rate, $59, for example, for an 18-year-old. Now it's $59 a month, unlimited care, and it's minus your tax rate. So whatever that is, it may be the equivalent of essentially like $40 a month or something of that sort, depending on that person's tax rate.
So does the employer pay you a monthly premium for his or her 10 or 15 employees, or do they fund the HSA and the employees then buy your plan? What do you I'm curious about the logistics, because I feel like the sausage making scares Americans about this.
Yep. The simple answer is yes. There's many different ways of kind of, whoever the sick person is that came up with the term skinning the cat. I don't know why that, but there's many ways you can skin the cat here.
Terrible expression.
Yeah, mainly we're talking about healthcare issues. So, yes, so there's many ways of designing that. How about that? That's probably a better way of saying it. Yeah, so you can just simply go, I'm not going to be involved at all. I'm going to give my employees rather, an HSA, and let them go either to their traditional insurance-based doctor as they wish, or they can go to a direct primary care doctor, whatever they want with it. That's actually a perfectly valid option. HSAs are amazing. You're not taxed on contribution. You're not taxed on growth because you can invest them. And you're not taxed on utilization as long as it's for healthcare. The patient owns it, so it rolls over year and even goes into retirement. So they have a wonderful incentive to rationally utilize it, which is, again, not in the current healthcare system. So you could simply do something like that. You could tell them, we have some who will offer us as a benefit directly paid by the employer. And some of them still offer traditional plans because a lot of these employees have good long-term relationships with their doctor. They don't want to break them. And I get that. I don't want patients who are forced to see me and unhappy. We have a wonderful, happy patient base, and I kind of like it that way. I like it when people choose us. So I don't want to interfere with somebody else's physician relationship. But they may say, listen, if you go to a direct primary care practice, maybe you have no co-payments on other things or something. There's many ways that those can be designed. So if somebody has a self-funded ERISA-based plan, they can design. There's incredible fluidity with how they can design that with a knowledgeable broker. And that's really important to say, too, because not only always do the brokers or the self-funded plans, are they even savvy that this is a very substantial emerging part of healthcare. So you want to make sure you're finding someone who's familiar with this to help you design that benefit package.
And is it your employer has to provide an HSA, or can anybody open an HSA themselves?
No, you can get them through. You have to. Unfortunately, there's limitations in how those are created. They have to be combined with a high deductible health plan. Now, those are in ACA. There are ACA, like the bronze plan I mentioned earlier, that technically could probably be combined with an HSA. Now, the problem is, again, the HSA plans, even the bronze plans, even the high deductible plans, which should be cheap because you're taking substantial risk on yourself by having that high deductible, are expensive. But at least you can mitigate that by having an HSA combined with them. However, if you have a health sharing ministry, if you have an indemnity plan, there's one called Atlas Direct that specifically works with direct primary care, and that pays you per medical claim. And it's a lump sum that can go towards medical service payments, but also it can go to lost wages, travel expenses, hotels, whatever. It can go to all the costs associated with that medical event, but it matches well with a direct primary care. And there are health sharing ministries that even will work with employers that are alternative coverage products to traditional insurance, like Sedera. I'm pretty sure Redeem, which is part of Samaritan Ministries, also does that, but they're faith-based, so it's mainly like churches and smaller employers like that. So there are quite a few options. Unfortunately, it can actually be mind-numbing how many options are out there, but that's a great blessing because for a while it was looking like we're going to have no other option other than the ACA, and that's turned out to be just a devastation for many people.
Did you ever think that you would be spending so much time with people educating them on health insurance or how to get health care versus on their health? Or maybe you do both equal amounts of time.
Yeah, never, ever. I thought I was just going to be a doctor and take care of people. But then I realized the system was terribly broken. And the more the government tried to fix it, the worse it became. And I started reading voraciously, to learn about healthcare financing. And I realized this is absolutely one of the most screwed up systems that we have. It is quite literally the most socialized system outside of education that we have in the United States. And not ironically, it's the most costly and inefficient.
So I'm going to ask you about the ICHRA in just a little bit so we can get a little more education. I'm not trying to be political in this question, but I want to understand if you ever have a chance to, because I know you work with folks on the Hill and trying to educate them on DPC care and some of the options out there. Do you ever get to meet with Democrats and educate them? Is there an interest or an appetite in understanding how this truly helps the patient afford healthcare more than Obamacare ever could? Yeah.
For the longest time, not a chance, mainly early on, because we were the counter to a single party payer, right? We're seeing the catastrophe of ACA right now as the subsidies are being debated. And when the subsidies are being debated, what they're saying is do we pull the mask off of ACA and you get to see it for what it actually is? Because the subsidies are hiding that. They're obscuring that. Well, people, and I actually thought maybe it was cynical at the time ACA was passed, that it was designed to fail. And Harry Reid at the time, who was leading the Senate, had even said it was step one towards a single party payer system. Right. So many people had surmised, and this is pure speculation from people at the time, that it was meant to implode and then be replaced by single party payer. Well, why would we not be appealing to people who desired that? Because we were the free market alternative to that. Now, thankfully, conservatives are now not the only ones who recognize the dysfunction of the system, and many doctors who have decided to go in this path are also on the progressive liberal side of the equation, ironically maybe not realizing that they're actually engaging in the free market that they vilify. But so because of that, we are seeing an increasing openness amongst the left wing of the political spectrum to direct primary care. And there actually may be some options out there that bridge the gap between those two ideologies, which, again, I don't know, we probably don't have the time to go into. This is more in the theoretical realm, but funds that the government could fund, but the patient controls and then purchases that for someone who truly is truly needy. And even though that would have problems, it would probably still be vastly better than the current pricing scheme that we have, which is controlled. People don't know this. Medical pricing in the United States is controlled by 32 members of the AMA called the Relative Value Committee. They set rates for Medicare. All private insurers basically base their rates on Medicare. So that means it's very Politburo-like design where 32 people are setting the prices essentially for all medical service in the United States.
Wow. That's incredible. So have you actually, well, let me ask this question first. The sort of the bridge that brings them together is that what you just described? Is that taking those ACA subsidies that have been revealed to be covering up how expensive Obamacare really is? In what the House passed, I believe that it was called the Lower Health Care Premiums for All Americans. And what was contained in that bill and what President Trump has been advocating for is to open HSAs for these Obamacare recipients and who get the subsidies and allow them to actually buy the insurance themselves.
Yeah, 100%. This is something I've actually been stumping for years because I saw it as a potential way of bridging the gap. I'm more conservative myself, but I have a lot of good friends who in the DPC community are quite liberal. And again, we see a lot of abuse within the with the EBT, the food stamp programs. But I would argue there's probably less fraud there than there is in medical. Medical is just bereft with fraud. And that's because, again, people become their own auditors when they have a set amount of money that they have to control. Right. Now, you're never incentivized to use someone else's money as judiciously as you would use your own money because you sweated for it, you bled for it. But they still use it probably better than a government bureaucracy does. So, yeah, I was extraordinarily thrilled when President Trump mentioned potentially giving those subsidies to the patients to purchase their own medical services. That is exactly what I think is a potential compromise solution. And many people on the left, actually, when you talk to them in private, are very open to that idea. We would just have to have
But that's in private. Have you ever talked to any Democrats on the Hill that would have an appetite for something like this and been able to educate them about the benefits and what you just compared it to, the EBT, with the with putting, I mean, they're grocery shoppers now instead of patients. And what they're trying to do is make the most of that money. And so they're shopping to get the best price and the best food that they can possibly feed their family.
Yeah, have I personally done so? No. But I will also say, in all fairness, I haven't tried in recent years. I know that there are some who I've talked to who I know have established relationships with legislators, and I've requested that they actually reach out. I know that some have done so. I don't know the results of those conversations.
I would just be so curious to sit down with a legislator on the other side of the aisle and have this conversation. And the analogy you just used is so powerful in what it means to put people in charge of spending the money, even if it's the government subsidies and they're being given that money. But if they're in charge of how it's spent, they have a stake in the game. They have a reason to find the best healthcare for the best price that meets their family's needs.
Yes, because because in essence, the argument is you're trying to help the poor. So you could subsidize the poor directly, right? Economically disadvantaged. That's the argument President Trump is making. For whatever reason, the counter argument is, well, the best way to help the poor is to give hundreds of billions of dollars to Blue Cross Blue Shield. Well, I'm not sure that worked out so well. Right. So, maybe circumventing them, they could still end up going to Blue Cross Blue Shield, but now it's the patient's ability to select that themselves, not the government doing it on their behalf. And then you get all the incestuous relationships that occur when you create those direct connections. I mean, we have a $5 trillion healthcare industry, which usurps all GDPs of every nation in the world except for China and America. We are the only countries with a bigger gross domestic product than America spends on healthcare alone. So it's the biggest part of the biggest economy that's existed in the history of the world, and there are sticky fingers galore trying to take their own piece of that.
Yeah, sticky fingers. That's a good way to call them. It sounds a little more nefarious, more accurate, more nefarious than middlemen. Middlemen doesn't sound so nefarious.
Yeah. I mean, there's inefficiencies throughout the system. I'd argue you could cut it by 50% by simply getting rid of the middlemen. But then when you consider that just flat out fraud above that, which again is really becoming apparent, Doge recently released their Medicaid data. And I know a lot of independent journalists are going through those, and they're finding like a popular story that was out right now is a gentleman who's practicing from a van and apparently has charged over $70 million from his van, reporting 1,000 claims per day from that van. Vans actually can be used for medical care. You could go to people's houses, do echocardiograms and such out of them, but 1,000 in a day is actually begs credulity.
Yeah, not likely happening. Not likely happening. Yeah. So, well, I want to in our last few minutes, I want to talk about ICHRA. Which is the Individual Coverage Health Reimbursement Agreement, and why small business owners should be paying attention to it. What is it, and why should small business owners understand?
Sure. So I think this was a brilliant idea, signed by President Trump in 2019 through an executive order. It was proposed by Brian Blaze, who's now at Paragon Health. And it basically allowed employers to create an HRA, which is analogous to an HSA, but the employer owns it, though the patient, the employee, employer-employee you can muddle those two easily. The employee controls the dollar, the employer owns and funds the dollars. But what's so unique about this and is different than HSAs and HRAs in the past is in ICHRA, the ICHRA, that employee can turn around and purchase insurance products with those dollars. So now, unfortunately, there are some limitations. You got to have it has to be an ACA compliant, Obamacare compliant plan. So that again limits your options. I would love to see a little, changing of the regulation around that to liberalize that up to be used for other coverage products that would really maximize its potential. But why this is so important is previously smaller employers had a lot of trouble offering a healthcare benefit because it's just simply too costly. They can't self-insure, and it creates a problem with competing against larger employments for talent acquisition, because even if you can match the wages of a larger employer, you may not be able to match the benefits package. So now maybe you can't offer a full healthcare benefit, but you may say, I'm going to offer $8,000 to you to help you go purchase a product that you like for you and your family. It may fully fund or it may partially fund that plan, but at least you're being able to contribute on a pre-tax basis towards that outcome, and that really helps the employee afford medical care, and it helps the employer with talent and acquisition and retention.
So I'm really glad you came on and we spent some time going into depth on this, because again, I think that Americans just don't understand that there are choices out there, and in fact, there is a lot of choices out there, but what we have to do in the alternative healthcare community is get to the small business owners and educate them so that they can they're the ones making the healthcare decisions for their company and for their employees. And if you could get to these small business owners in mass numbers and speak to them in terms of not just the savings, although that's very important to a small business owner, but that it wouldn't be so scary for their employees. Because remember, they don't want to scare their employees in terms of this is what you're going to see. This is your experience as a patient, as an employee using this health insurance, and it's not going to be scary, and it's going to be better, and you're going to have better care and better health outcomes. But I really think that the DPC community and you've been doing this because I've worked with many of you for a long time. If we could figure out a way to get the message out better to small business owners, and we started to have this movement of there's 30 million small business owners out there. I mean, we could, if we could reach, 10% of them, we would really start to see a movement that's bigger than it is now. And I know it's grown over time, but I know there's a lot of forces working against doing that. And those are the forces that want to go down the path that Harry Reid talked about back in the day.
Yeah, yeah. And a lot of people's income and livelihood is based on the bureaucracy and the waste. I mean, there are people who have, degrees in billing and coding. Well, it's a human-made construct, and unfortunately, we're talking about making those billing coding degrees irrelevant. So people obviously who hold them and jobs are involved with them probably aren't thrilled with what we're offering, but we believe that this is better for society. Well, I think gradualism is part of it. So as more people learn about it, thank you to yourself and Job Creators Network for bringing attention to these things. People will start to adopt them gradually over time. That's actually probably good, because the system in reality couldn't just flip over immediately to this kind of system. It would be too disruptive. But if we start changing 10% a year or something of that sort, you're going to allow that gradualism to a more functional system. This system is so broken, it was decades in the making, and it may take years to still correct it.
Yeah, you've got to create the supply and create the demand almost at the same time.
Yes, there is a critical mass of people requesting it and people providing it. I am thankful to God that I think we are to the point where we are actually meeting that critical mass now. The next big step will be for that critical mass to be high enough of patients that the specialists will be able to more easily follow suit. And then we'll really see a revolution within healthcare as free markets and the constraints they have on the excess of pricing and the inhibition of the detriment they are to poor quality doctors. If you're a poor quality doctor, you're probably going to go out of business in a free market-based system. That's a good thing. You don't want bad providers out there, and it's kind of a self-regulating mechanism. But once those forces take hold in medicine, which are largely not there now, you're going to get better prices, better quality, healthier populace across the board. We do more lifestyle education in my practice now than I ever was able to do in an insurance model because we're afforded the time.
Well, Dr. Savage, thank you so much for coming on. I really appreciate it. Can you tell everyone where they can find out more about you, follow you on social media?
Sure. I'm on X. So, and I can't even remember my handle offhand. I don't use this for self-aggrandizing. But if people want to learn more about my practice specifically at yourchoicedirectcare.com, we are probably a similar, you'll find similar practices near you. We're not related. We're all individual practitioners. If you want to find a practice like our own, you can go to DPC Mapper. If you plug that into Google, it's a map with a bunch of stars. It's not all inclusive. There are DPC docs who aren't on this map, but it's a fairly comprehensive list of DPC practices, and most people can find one near them. They can work with them to try to get a plan that incorporates DPC to help their employees.
You can even just go to Google and just type in direct
DPC
primary care
right.
near me, and it will pop up. That's how I found my DPC doctor as well. Well, Dr. Savage, thank you so much for taking the time to join us, and thank you all for taking the time to listen to Main Street Matters, America's small business megaphone. Main Street Matters is part of the Salem Podcast Network. New episodes debut every Wednesday and Friday. You can subscribe to the show wherever you get your podcast from, and we will be back soon with another episode.